Hello there. My name is Arafat. We are back. We are speaking with Professor Nkusi Agabe, who is a neurosurgeon. We are talking about the ATLS. So today we are back with our second episode. We want to continue and understand and get deeper understanding of this chapter that was recently launched. So, Professor, we were talking about you were telling me about how they'll be sorting out patients depending on the severity of the issue. So, I think we've really understood that. So, I wanted to ask you a very, to me, I think it's a serious question. As someone who has been, you are a renowned neurosurgeon, you've done a lot of work in that field. Do you have a case that you can really tell us that you handled? ATLS was there. You're quite certain someone would have not died. Do you have such cases that are ringing in your head that you think really would have been?
So, thank you very much for the question. I'll answer it in a way that may not be directed to what you asked, but every week we do what's called a morbidity and morbidity. Okay, as a department, we discuss every patient that we handled. And remember,
every week?
Actually, even it's like every day. When we receive a patient, if you're on call, you are on call with residents, remember? And you are working with other people that are working at emergency. So when you receive a patient, especially those delays, you know, in those delays coming from this place, going to another place, because of different reasons. So those we see many because of the way the system is arranged. So say if you got injured and you are in Rusizi, you first go to another place is going to refer you to another place, then eventually you're going to go to Butare before they go to, say, CT scan, then they send you to here. So without being direct, you can see there is a huge delay and the outcome is going to be different.
Sure.
So that's why, as I told you, is that so the Ministry of Health is organizing the hospitals in such a way that those delays are curtailed. They are significantly reduced. The transfers are significantly reduced to cut on the golden hours I was telling you about. So to try to achieve the golden hour. So you have hospitals, trauma centers that are capable of handling majority of cases in different provinces. So we looked at them in different provinces. At least we should have a hospital that's capable of handling serious problems at if you look at it at provincial level. So you should have at least two major hospitals, one of a very high caliber followed by another one or two, different depending on the different locations. So we also looking at the distances to reduce the distances people travel to get care, access to emergency care. So all that is being taken care of. So hopefully, maybe in a year or two, we'll give ourselves about 5 years, should be able to
put it in
place. So that you don't have to travel a long distance to get care after trauma, serious trauma, or even other emergencies will be handled the same way. Because if you build an ICU trying to handle traumas, they also handle asthmatic attack, they handle stroke, they handle, so all those, there'll be the pre-hospital people will be able to direct them to different hospitals according to their capabilities.
Okay, so doctor, the emergency medical service play a vital role in trauma care. How can Rwanda improve its emergency system to complement with the ATLS?
So as basically what we're trying to do
is resolving putting.
The golden hours I told you. It's like everything's going to be built around that. In other words, the golden hours, there is no magic about it. Is saying that we get a lot of problems after 1 hour. So if you can solve people's problems or emergencies within 1 hour, then we're going to be saving a lot of people with less disabilities. You understand? So be it severe asthmatic attack, be it stroke, be it trauma. So we are looking at it. So if you have, say for example, each region, if you can have like each say district hospital, if you can have like 2-3 ICU beds, if you can have a person capable of intubating a person and ventilating, and you have a ventilator there, people are going to have oxygen going to their brains, and the hearts are going to be resuscitated properly, and so we're going to reduce deaths as well as complications.
So simply ATLS is part of the EMS.
So ATLS is part
of improving EMS.
Exactly.
Okay.
So we have ATLS, we're going to have one for nurses. So ATLS is basically for doctors. Now we have advanced trauma care for nurses.
ATLN.
ACTN.
ACTN.
Yeah.
Okay.
Yeah. And then we have pre-hospital also. There is also called pre-hospital trauma life support. That's what we're going to train with those ones. Now we have advanced cardiac life support. So those are short courses, but are very systematic in the training, to the extent that a person who's trained in those, before you're certified, you acquire skills that can help you work quickly in those.
Do you have a specific number of people that you, or doctors you want to train in this chapter? Do you have a specific number that you're looking up to, or are you trying to make sure that at least every doctor has knowledge about it?
Every doctor, that would be, actually it's going to be, because if we have spread out to the trauma centers, then each person who's going to work in the trauma center is going to be certified in ATLS if he's a doctor. If he's a nurse, he's going to have ACTN, or what we call TEAM, Trauma Emergency Evaluation and Management. We're going to so the pre-hospital, the paramedics are going to be trained as well. So, and then it's a continuous. It expires after, say, ATLS expires after 4 years, 5 years.
So every 4 years there will be
refresh.
You refresh.
Yeah.
And get another certificate.
Yeah.
Okay. They'll be doing refreshers every 4 years. Every 4 years.
Yeah.
Oh, okay. That's really.
And then of course there are many other courses for the people. Remember, doctors are not working alone. As I said, with nurses, the paramedics, so there are many other courses. And of course there is training of nurses, the formal training. After that, you train them with that. So that's enhancing the emergency care management. So
apart from the ATLS, what do you think, or what are some of the other initiatives that Rwanda the Ministry of Health can put in place to ensure that there is highly improved life of, the emergency system, improving the emergency system?
So
which other things that can be put in place?
Other than those that are talking about nurses, or the healthcare providers, the infrastructure. Remember, you cannot bring a person to a hospital if the hospital is not ready. So the hospital, the infrastructure, we're looking at emergency rooms. So we're looking at each hospital having an emergency room.
And an emergency room requires to be equipped with everything for emergency.
For taking care of the airway at least. You should maximum a ventilator, because this is a person you're going to save if they cannot breathe for themselves. There should be a machine to breathe for them. Now, if it is a person that requires to go to theater, you should have an emergency theater. That this person, because in the triage system, as we said, this person comes, is assessed quickly. The resuscitation sometimes, part of resuscitation is surgery. Easy bleeding in the somewhere. If you don't stop the bleeding, the person is going to die. So one of the ways to do resuscitation is to take the person to theater. So there should be a theater, emergency theater, ready to take the patient. And of course, there should be somebody who's capable of putting this person to sleep. That's an anesthetist or anesthesiologist. And there should be a surgeon to operate on the person.
So, for the public, I mean, like for the person like me or my friend or my brother or everyone out there, what skill do I need to be able to, I mean, play a role or support and have the ATLS purpose get fulfilled?
Yeah. So thank you very much. Actually, it's a very nice question because it brings me back to what the task force is busy doing. In Rwanda, we're thinking of having different levels, trauma or emergency and trauma levels. So the last one, which is the sixth one that is not anywhere in the world, but we think we're going to be able to have it.
So you're going to be the first one to have it?
Yeah, because
it's not anywhere in the world.
The sixth one that I'm going to tell you to explain what it is. It's because we have community health workers, and they are not anywhere else. So the community health workers are also going to be trained in their language, in the Kinyarwanda. We're going to teach them how to handle emergency, and also how to handle emergency, but also people when they go back to community. We haven't gone. I'm going to take you through what it requires to have a very nice system. When people go back after we operated them or after the severe injuries, they don't have good care. Now, the problem is they may not go back. So a doctor writes, go back to, you go and do physio from home. This person is got injured and his mind, he thinks, nawa ichimuga. So this person needs encouragement. Yeah. So the community health workers are going to be given those skills to go also take care of those patients that have had emergency care because it's traumatic. So they can get depression and all that. So they're going to be taking care of them, look after them, tell them, encourage them, go and encourage them. Like they do with TB and other things. So they'll go there and encourage them to go back to hospital, nearby hospital to do physiotherapy, to walk, instead of lying in bed. Because lying in bed also has its own complications. So we think that level, the last level, they can also be advocates of, if an accident happens in the area, they should be able to, one, to call ambulance.
Oh, two, to play the role of the golden hour.
Yes, to help actually. Sometimes because when we try to pull people from cars, we damage them.
Yeah.
So if they are capable of assessing the damage of the car, then they stop people from trying to extract people from the car. That is also important. Because then when the ambulance comes,
Doctor,
they should be able to save those people.
Talk about that. Simply talk about that. I mean, how should someone pull out someone from a car? I mean, because as you said, we rarely do that. We rarely take serious that if I pull this guy out of the car, I'm likely going to cause another damage to the whole body, which I don't know.
So for example, if a person is injured, and you find a car has crashed and is squeezing the guy and you try to pull. Now, if he's got a neck injury and you pull, that's why we say when you handle an injured person, as much as you want to clear the airway so that he can take in oxygen, you make sure that the neck is protected. Because otherwise, you allow oxygen to go, but then you damage the neck, and then this person is going to be paralyzed in the limbs. So now you made this person permanently damaged, yet the damage wasn't complete. If a person comes, the paramedics, when they come, they wrap around the neck a hard collar. So then this person can be extracted from the car.
without having the...
without damaging their necks to cause them to be paralyzed.
So simply, if let's say I'm at the scene of accident, and as you said, maybe someone is caught in between of the two crashed cars, how should I assess
One
that?
of the best,
How should I assess
ways,
that?
the starting one, you can call them. They keep talking to you if they can talk. Then you call the ambulance. They come and help this person easier. So, because if you talk and hear them talking, it means at least they can take in oxygen.
You first call them and
hello.
have them talk to you. Then after?
No. As you talking to them, you can just keep talking. Then you call ambulance to come and join.
So it's not advisable to take the action.
If it is difficult, do not.
Do not.
Because you damage them. You make them worse.
Okay, that's really wonderful.
Yeah. So if I can quickly take you through what's going to happen. So we have had pre-hospital. We have had preparing the hospitals. That's they have where to receive the patient. That's the trauma rooms. Then they have intensive care places where they take very sick ones. Nzwindembe. Then you have operating room. Now you've taken care of those very injured patients. Now when you finish treating them, or during even when they're still in hospital, you should have people the so-called rehabilitation. So that's something also we don't take serious. So rehabilitation, when started early, reduces disabilities.
And that is the job you want to
diseases.
Give community workers.
No, that's the last bit of it.
Okay.
But in the hospitals, we want each hospital to have that capacity to rehabilitate, to start rehabilitation. So we have two types of rehabilitation. We have acute rehabilitation, and we have the chronic rehabilitation. When people have gone to their communities, we call it community rehabilitation. Yeah.
But the acute rehabilitation will be done inside the hospital?
Within the hospital.
Okay.
So then you have the people that are responsible for that. So you remember if they're traumatized, so you have physiotherapists. You're going to have, if you're paralyzed in one hand or one hand is cut, you should have people that are called occupational therapists. You should have even counselors to counsel people when they're severely damaged. Or if you've lost your limb or you cannot talk, you get depressed. So you should have counselors to talk to them, to support you, to keep supporting. So then the chronic rehabilitation also will have all that, plus community and also the families to teach the families how to support their own people.
So looking at Rwanda ahead, I mean, where do you see this ATLS and improved emergency system taking us? I mean, and how should we get there?
Yeah, so it's a stepwise thing. Like the health system has been. So, for example, now we know, I think you've heard of it, the 4x4.
I know.
Yeah, so you've had the 4x4.
I've
so
heard
these things are coming all at the same time. It's not by accident. It's planned. So now, the 4x4 is happening across. It cannot be among doctors only. It's nurses, doctors. Now we're going to add paramedics. It's all those. So if they're trained, now you add on top these courses. They're short courses, but they are very systematic with protocols that they need to follow. Then they become very good professionals. Whether it's going to be looking at the heart and related diseases, or asthma and related diseases, or trauma. So all that we are looking at it as a system. So the 4x4 is answering all this because that's why you're going to get the people to train.
But Professor, like you are one of the founding fathers of the health sector in Rwanda, and you've really seen everything happening. Where do you rate Rwanda now? I mean, the health sector. If you were asked to rate it, where would you rate it? Do you think have we moved, like, let's say out of 100? Maybe where are we?
It depends. It depends on each. I think I was looking at
general,
statistics.
because you've
I was
seen
looking
it
at the
happening.
statistics in today. Some statistics talking about what we want to do and where we want to be. For example, I think the doctors' training is about 9%.
9%?
That we want to achieve. I think the nurses have something like 29 or something. I have the data. So we're still very far
Really?
from where we want.
9%?
But we have moved a lot.
I mean, 9%, that's what we want to train.
No, it means we need 91%.
I mean, that's what I want. That's what I was asking. We need 91%, and we at 9.
Mm-hmm.
I thought we were about 70.
No, we're still very far. But that's coming from where?
Oh my God!
Because remember that
We are coming
in
from
the 90s,
zero. Yeah.
For us, we were still medical students. When after 94, I was still a medical student. But we used to come and we are like, we are doctors. We are you finish today, you taking care, you are in charge of
the whole hospital.
Emergency and everything.
Oh my!
You do surgeries, you do what? So we've come from very far. I think even just recently, in 2007, when Rwanda Surgical Society started, we had, I think, about 7 surgeons. Now we have 163.
Currently, how many?
I think there were 7 surgeons when the Rwanda Surgical Society started.
Are you aware of the number of surgeons we have today?
Yeah, that's what I'm saying.
Currently,
yes, we are 163, I think.
163.
Yes, across the board, the surgeons.
And you
remember in 2007 when the society started, I think there were about 7.
Okay.
So, as I said, it's not one thing to solve the problem. So ATLS is coming as part of EMS and trauma system that Rwanda is working on. It's slowly but steady. So some offshoots are coming. You can see the ambulance systems working. Is heading somewhere. The ambulances have some core system. The stations have increased. Of course, the hospitals, the work is being done there.
It is also going to leave the burden on doctors, I think. Because
so
when you receive a less severe person, maybe
it's going to be managed somewhere because now you are systematic, even the paramedics will know not to bring this person is going to go to maybe a level 3, a level 4. Yeah.
Okay.
So when you make things systematic and they're written, you have protocols. It is easy even to direct somebody.
Go do this.
Just do as they are there. Just do this, and this person is covered.
Okay.
So it gets the confidence that is spoken to you, and counsels the patient, and that will be there.
Thank you so much for watching the Voices podcast. My name is Arafat. We've been speaking with Dr. Professor Agabe Nkusi, who is a renowned neurosurgeon in the country. And actually, we've been talking about the ATLS that was recently launched in the country. And I think you've heard about it. And actually, we are very excited about it because, as he said, so many people were losing. We are losing so many people in this process. And he's talked about the 1 golden hour, where they hope even to train us, the ordinary people, to know how to treat people in 1 hour of the trauma cases. Thank you so much, guys. See you for the next time.